immune therapy pre or post. And I think for the press conference, we're going to switch the order from what we did at the presentation. And our next presenter will be Dr. Mariano Provencio. Dr. Provencio will report on his abstract progression-free survival and overall survival in the NADIM-2 study. Dr. Provencio is president of the Spanish Lung Cancer Group, head of the Medical Oncology Service at Hospital Puerta de Hierro in Madrid, and has been appointed to be an associate professor at George Washington School of Medicine and Health Sciences this academic year. He is scientific director of the Health Research Institute of the Puerta de Hierro Hospital, and a professor of medicine at the University of Madrid. He's received numerous awards and is very well known in the field of neoadjuvant treatment. So welcome, Dr. Provencio.
Thank you very much, and good morning, everyone. I would like to present our NADIM study. This study is focusing on locally advanced disease. Dr. Torki has been presented in early stages. This is in intermediate stages. In this case, we have very poor prognosis in these patients. These patients have N2 affectation. This is mediastinal disease, and you can see this mediastinal disease in CT scan. And also we focus in T4 group, patients who have more than 7 centimeters maximum diameter, or involvement different, for example, heart or diaphragm or other. These specific patients have very, very poor prognosis. We treat these patients with several approaches. The standard of care is treat these patients with chemotherapy, neoadjuvant chemotherapy as induction treatment, and then evaluate the situation, surgery or no surgery, or radiotherapy after that, or concomitant radiotherapy. In any case, we have the same survival in the last 40 years or 30 years. It's around 30% of the overall survival at 5 years. And the preoperative chemotherapy, neoadjuvant chemotherapy, the absolute improvement is only around 5%, no more. And we have shown several surrogates. For example, in my opinion, the most robust is the pathological complete response. This is when you can see any tumor cell in the resectable specimen after the treatment. But with using neoadjuvant chemotherapy, the rate of this response is very low, around 4%. Now we have very, very exciting results with NADIM-1 and other clinical trials using neoadjuvant nivo plus chemo or other immunotherapy with very high survival rates, and also high percentage of PCR, the pathological complete response. I mentioned before, it's in my opinion, very good surrogate. And also we have the data about the Checkmate 816. Clinical trials is developing patients with more early stages from 1B to 3A, but the results are very promising, improving the median event-free survival and PCR, but with more stages resectable disease. In our NADIM-2, I think there is more specific and poor prognosis in these patients, and N2 affectation, clinical affectation, histologically proof, and then also T4 disease. We presented at ASCO the primary endpoint. It was a pathological complete response. It was higher than the control arm. You can see here almost House ratio 7.88. And this is the study design. Patients with locally advanced disease, N2 disease, histologically confirmed N2 disease. The randomization was 2 to 1, 2 experimental arm, 1 control arm. The surgery was performed after the 3-4 weeks neoadjuvant treatment was completed, and patients who achieved R0 surgery received adjuvant treatment for 6 months. These are the primary endpoint, the secondary endpoints. we have to present now the secondary endpoints because we have now 24 months of median follow-up. The baseline characteristics show no statistical differences between the two arms, but you can see here almost 72% have N2 affectation. I mentioned before it is very, very poor prognosis in these patients when have clinical affectation and N2 affectation, and also multiple affectation, multiple station in Hafalden. This was the flow diagram. The randomization was 57 experimental R, 29 in control R. The majority of patients received the planned dose. And some data about regarding surgery, for example, the 93 patients underwent surgery versus 69 in control R. Odds ratio 5.96, very high significant range. And also the resection degree was high in experimental R, 92.5% versus 65%, odds ratio 6.60, p-value 0.07. And also nodal down staging was high in experimental R, 69.8 versus 40% in control R. The progression-free survival with median follow-up 26 months was longer in experimental R, hazard ratio 0.48, p-value 0.025, and as you can see here, the percentage of the progression disease in each of the time. And importantly, the PFS according to pathological response, you can see here the patients who achieve complete pathological response, no tumor in the specimen, all are free of disease at that time. And also we have data about overall survival, and also it was longer in experimental R, hazard ratio 0.40, p-value 0.03. And here the overall survival according to pathological response, and you can see 100% of patients who achieve PCR are alive at that time. Our conclusions about the confer the superiority of nivo plus chemo in this setting of patients, in neoadjuvant setting, in neoadjuvant approach in these stages. The addition of neoadjuvant nivo plus chemo significantly improved the PCR, the pathological complete response, improve the progression-free survival, improve the overall survival, did not impede feasibility of surgery with safety profile, and also is the first clinical trial with neoadjuvant immuno-based combination to show improved overall survival in these stages. Thank you very much.